Okay, so thank you everyone for coming out to Carolina Health Samaritan Society's virtual medical shadowing event. Today, I want to welcome UNC pulmonologists, Dr. Drummond and Dr. Patel. We are very excited to have you both here today and to learn a little more about your medical specialties and educational journeys.
Great, thanks so much, Margaret. So I'm going to introduce myself first, and I'll let Brad introduce himself next. So my name is Kunal. I'm an assistant professor here. I've been here, this is now starting my 4th year. And we have a couple slides into the talk where because this is a virtual shadowing event, to where you can kind of see what both our timeline was, or pathway was to get here, and what our lives are like and now that we are here. So more introduction to come, but.
Yeah, hey everyone, thanks Kunal. I'm Brad Drummond. I'm an associate professor at UNC in Pulmonary with Kunal. I've been at UNC now for about 6 years. So we're not lifers, but we're growing roots, I guess. And I'm excited to be here and just have a chance to talk to you all about the awesomeness, I think, that is pulmonary diseases and critical care medicine. So hopefully you can get a good sense of what we do. And I think I'll speak for Kunal, but feel free. I don't know if there's a chat or if people want to unmute and jump in, interrupt. It's, I think, totally informal. So stop us if you have questions.
Yeah, absolutely. Absolutely. And then in addition to our field, what we're hoping to talk a little bit more about is what does it mean to be in academic medicine at a place like UNC? And I've kind of taken a circuitous path to where I am now. Brad's also had a few kind of offshoots, but we do slightly different things within the larger realm of academic medicine here. So, okay, so an overview of the next hour, we're going to introduce our field of pulmonary diseases and critical care medicine, commonly abbreviated as PCCM, going over what academic medicine is, go over our paths, and then we thought it'd be interesting to kind of show it's not so much a day in our life, but an actual week in our life, because there's so much difference in what we do on a day-to-day basis. And then also kind of from week to week, it can really vary. So we'll give 2 different models. One is when we're working in the hospital, and the second is when we're not working in the hospital. We also wanted to highlight some of the diversity of patients that we see in critical care medicine, in pulmonary and critical care medicine. So we're going to talk about that, and then some tips and just sort of lessons that we've learned over time in academic medicine. So kind of first, what is pulmonary and critical care medicine? So, pulmonary focuses on the injuries and diseases of the pulmonary system. So most commonly the lungs, but then also the airways that lead into the lungs, so the trachea, and then sometimes neuromuscular diseases too that can affect the diaphragm and other muscles that help you breathe. We can kind of, when we think about the lung as a compartment, you can then think about some of the different diseases that can affect the lung. So we have airways diseases. So I think of the lungs as a series of straws, and those are the airways, and leading to a bunch of balloons. That's the lung parenchyma. And so we have diseases of the straws like asthma and COPD, cystic fibrosis, which UNC is kind of a world leader in both the research and the genetics of cystic fibrosis and in the treatments that have now come online. Second is a group of diseases known as parenchymal lung diseases, and this is like diseases of the actual balloons. So pulmonary fibrosis or lung fibrosis is a very common one. And then third group is when we think about gas exchange, air is going through these straws, blowing up the balloons, and then we actually have to have blood vessels going through the walls of the balloons to pick up oxygen and drop off carbon dioxide. And so you can also have diseases in that compartment, and that's known as lung vascular diseases. So blood clots or a condition known as pulmonary hypertension that can develop secondary to blood clots or other diseases of the blood vessel. So that's part of our field is pulmonary disease. The second part is critical care. And critical care focuses on life-saving care for patients with any severe organ dysfunction. So this can be a failure of the lungs and breathing, a failure of the heart and circulation, severe infections that can lead to a condition known as sepsis. You can also have other organ failures, most commonly the kidney failure and liver failure. And for critical care medicine, there's different pathways into critical care medicine. Out of internal medicine, it's usually pulmonary and critical care that get grouped together. And so we spend time working in a particular type of intensive care unit called the medical intensive care unit, which really focuses on these types of organs failing. These are not post-operative patients, but these are patients that are coming in from home or they're already in the hospital and then develop one of these life-threatening conditions. I think, there's some really unique skill sets that I think are important in our field, and I think also make it fun for people like Brad and I. So one is that while we're not radiologists, having a good foundation and interpreting radiology of especially the lungs is really important for us to do our jobs. So we're all pretty good at thinking about chest x-rays and CAT scans, which is cross-sectional imaging through the body to help kind of guide our understanding of the diseases that affect both pulmonary diseases and in the ICU. There's a lot of physiology that's involved in pulmonary medicine in particular. So there's something known as pulmonary function testing, which is like kind of how you get air in and out of the body, and how it tells us a lot about where you have a problem in lung disease, whether it's the airways or the parenchyma or the lung vascular disease. And so we interpret those tests. We do procedures, so things like bronchoscopy, where we go in through the mouth or the nose and then go into the airway and can sample different parts of the lung in various ways. And Brad's going to talk about that a little bit later. There's also a space known as a pleura, right, which is a lining that surrounds the lung in the chest, and things can fill in that space. So we can have fluid that can develop there, secondary to infection or cancer, or blood clots even, or heart failure. And so some of our colleagues can also do procedures in that space where they put needles in and drain that fluid, sample it, understand what's causing it, and then do further treatments for it. And then in intensive care medicine, there's a lot of procedures, including putting in breathing tubes known as intubation, putting in large IVs, those are known as central lines, so we can deliver medications that help with particularly like heart failure or severe infections that keep the blood pressure in a safe range. We use ultrasound a lot, mostly in the ICU, but we are trying to do it more also in clinic. And I think as you guys start your medical training in a few years, you'll find that we're teaching medical students how to use it more and more because it's such a portable way of doing diagnostic studies. And then there's a really important emphasis, both in the ICU and I think in pulmonary diseases, around palliative care and end of life. And so these are skills from patient communication and understanding patients' values and kind of guiding care to meet those values that we also have to be, quite facile in. With that, I'm going to hand it over to Brad. He's going to talk about what does it mean to be in academic medicine.
Yeah, so I think Kunal did a very nice job there of explaining what we do on a daily basis and a weekly basis, and really it's an incredibly broad array of things. And I think that's I'll probably speak for Kunal, but part of the joy of what we do is every day is not the same, as you'll hear about later, because of that depth and breadth of what we do. But one of the things to think about is, well, where are you doing those skills? And that's where I think it's important to understand. People toss out words like academic medicine or private practice and those sorts of things. And both Kunal and I are practicing all those things that he just described. We're practicing in the sort of under the roof, if you will, of academic medicine. So typically this means that you are employed by a university, a hospital that's affiliated with university. Both Kunal and I are employees of the UNC School of Medicine. That's sort of where we live, if you will. And we work with a hospital that's affiliated, or the several hospitals, at least two hospitals that are affiliated with University of North Carolina, Chapel Hill. And all of our clinics are directly affiliated with University of North Carolina. So we have clinics in Chapel Hill, Panther Creek, sort of across the outreach of the sort of region, but at the end of the day, we're affiliated with the university. And that's, I think, really what it means to be in academic medicine. And this is different. The other extreme would be something called private practice, which means that you're working with an independent group, or you may be working with a larger healthcare organization that sort of employs you, that perhaps you're unaffiliated with a specific university, or you may be affiliated with a freestanding hospital or a freestanding clinic or clinics, but you're sort of the roof you work under is not directly related to a university setting. And there are some positions where it's almost a hybrid, where you sort of have a part-time appointment in an academic versus a private. So there is a spectrum. I don't want you to think it's sort of a binary, you're either one or the other. But for those of us who are in the sort of academic space, we really affiliate with a university. And so what does that mean as far as what our different sort of tasks are? And really, most people in academic medicine are going to focus on really three different broad tasks. And most of us do all of these to varying degrees. So the most obvious is perhaps the clinical care. So that's actually taking care of the patients. This can occur in the hospital settings, such as the UNC main hospital, the Hillsborough Hospital for us, in our clinics that are sort of scattered around the community. We also, I think what's unique to academic medicine are the other two components, which are really the emphasis on education and research. So this is sort of the three legs of the stool, if you will, the clinical care, the education, and the research. And so by education, I mean that we take on, as part of our responsibility as being a physician, teaching really up, laterally, and down. So this means teaching our colleagues when we give talks at medical grand rounds, or to our journal clubs with our colleagues, teaching our medical students. So these are the folks who have come, as you know, coming out of undergraduate training or other pre-medical training. And then after medical school, after medical school, you then move on to residency program, which is sort of the next layer of that. And then if you decide to specialize in a certain area, you then go on to fellowship training. And so when we are doing our clinical care, we're often doing it surrounded by medical students, residents, fellows, not only in medicine, but also in the School of Pharmacy, and other areas. And so we're really responsible for facilitating the education of those, of all those different layers. And whether that's by formal didactic lectures, frankly, what we're doing tonight is something that I think we consider sort of a part of our education, whether it's teaching somebody at the bedside how to do a procedure, how to put in a central line, or do an intubation. So all of those things are under that rubric of education. And then finally, the research side, which I think is something that's often unique to an academic medicine career, is where you're actually trying to either take lessons that your scientific lessons, or questions you're observing from the patients you're seeing, or from your prior background in research, and then trying to use your scientific skills to advance the understanding of disease processes. So this may be what we call basic science or bench science, which is where you're really doing cellular studies, maybe animal models, smoke exposures in mice or something like that, that really is very mechanistic and very biologic, understanding the mechanisms of disease. And then clinical science is where you're actually doing research on people directly. You may be deploying surveys to understand sort of outcomes in the ICU setting. You may be following people longitudinally for a disease process. They're doing breathing tests as part of a research study for 3 to 5 years. And then there's the middle road, which is called translational science, which is where you're doing some combination of perhaps biomarker mechanistic work that is involving people. And as an example, I do translational research, and we did a study understanding how vitamin D may impact lung function or lung outcomes in patients with chronic lung disease. So we would do sample collection in the lung and the blood, and give the participants high dose vitamin D pills for 8 weeks, and then resample them. So we're trying to understand biomarkers of disease. So in the academic medicine portfolio, if you will, most people are focused on an area. So I identify myself as a researcher. I think Kunal identifies himself as an educator, but the reality is, as you'll hear, we do all these things. And so I think that's how kind of what defines academic medicine. I think we can, unless Kunal, you have more to add, we can go to the next slide there.
Now, does anybody have any questions about that though? For those who are joining, we're happy to discuss as we go too. So. All right, well, please do speak up as questions come up. So next we're going to talk about our paths and how we got to the job we have here. So kind of my path, so I was born in India, but I immigrated to the US when I was 3. So much to my extended family's annoyance, my language skills and cultural skills are actually quite poor. I grew up in San Antonio, which is what the little photo here in the corner is for. We have a highly successful NBA franchise, or at least was highly successful for 20 years. I did my undergraduate at Washington University in St. Louis, and I started there in 1998 and finished in 2002. And some of the things I was doing as an undergrad, I was interested in medicine even at that point. So I was thinking about some of those activities I did were helpful or are helpful now, and some of the things were just trying to make me things I enjoyed and things that I think made me a well-rounded person. So I was a college EMT, which gave me some exposure to medicine and taking care of patients. But I was also an RA, and I really loved that, and it helped me sort of relate to people and figure out kind of my personality and counseling and talking to people. And there's some education that happens there, right, as a RA to freshmen. I did a work study. Had a work study assignment in a basic science lab that studied urinary tract infections and the bacteria that cause those. And from that, I started a research project, and I really enjoyed that, and led me to do some basic science research and like sort of a cell culture model. And I did that for the last couple of years I was in college. And my majors were both biology, and I also was a religious studies major, just something that I enjoyed kind of learning about. So after college, I forgot to actually write, I took a year off. I did a gap year where I worked for AmeriCorps, and I did a program that looked at pharmacy benefits and how to help patients get better pharmacy benefits in the DC area. And then I started at University of Pennsylvania in 2003, and I did both an MD and a PhD. So I did 2 years of med school, took a long break to do a PhD, and then came back and finished medical school. And I did my PhD in basic virology, so studying a group of viruses called picornaviruses, not coronaviruses, but picornaviruses, and how they got into cells. So again, very basic science. I did my residency in internal medicine. So that's the first level of training for pulm critical care. You do an internal medicine residency, learn about all the basic medicine fields, so cardiology, pulmonary, GI, general medicine. Did that for 3 years at Brigham and Women's in Boston, and then came back to Penn and did my fellowships. This is subspecialty training in just pulmonary and critical care medicine for 4 years there. And during that time, I was again thinking I might want to do basic science research. And so I spent time working in an immunology lab and studying how T cells, which is a part of our immune system, responded to influenza, and using an animal model for that. But while I was doing that, I was also got the opportunity to be a chief fellow. So I got to do some medical education and some medical administration, or medical education administration. And when I decided to look for a job, I decided I didn't want to do the basic science anymore, and started here in 2018. And I have kind of formally left research behind as far as a big part of my career. And so I mostly do clinical and education, but as we'll talk about later, I do still do a little bit of collaborative research. A little bit about me as a person: my wife is an oncologist here at UNC as well. We have 2 young kids. And I'm the first member of my family in medicine, and my wife is the first member in her family in medicine, but she now has, her sister's a nurse practitioner, a younger cousin's a cardiologist. So we have both that experience of being the first people to go through this, and then also having some support as we're going through this now. So I'm gonna hand it over to Brad again.
Yeah, and we have some similar overlap. But but different paths. So I think it's interesting. And actually, I learned a lot about Kunal just in his slide right there. So even though we've been together for a couple of years. So I was actually I'm also from San Antonio, Texas, and I did not know Kunal, which is, I guess, shows the small world. I'm the middle son of 3 boys. My dad is now a retired private practice gastroenterologist. So he worked for a small 3-person practice in San Antonio, Texas, and was sort of doing clinical care all day, every day, 365 days a year, minus every third holiday, or worked every third Christmas, every third holiday, every third everything, because it was 3 of them. My mom was largely was initially teacher and a stay-at-home mom with 3 boys. She's the angel, right? So I, after graduating from high school in San Antonio, I did my undergraduate at Emory University in Atlanta, Georgia. And there I did, I got a Bachelor of Science in biology. I was also an English major as well, although that was sort of my side interest in that. And maybe it's helped me try to be more empathetic in medicine, I guess. The liberal arts side, I think, is a good side to have. I did do some basic science research in college. I worked in a laboratory that was interested in understanding how the eye helps the body make melatonin for your circadian rhythm. So I was involved in studying chick photoreceptors, like baby chicken photoreceptors that were cell cultured in a different light dark cycles. So I would often have to go into a dark or a red light room and try to replace cell culture fluid and harvest cells from the retina, or grow retinal cells. So something very different than what I do now, but that's where my first sort of interest in science came about. And then I also was a teaching assistant in a biology class, actually all 4 years. And I have to say that probably was one of the most useful things I did looking back now was being involved in being a teacher or teaching assistant. I think so much of what you do, especially if you stay in academic medicine, is thinking about how to organize thoughts, how to explain ideas, how to explain concepts. And this is both for medical students, residents, fellows, but also for patients. I mean, trying to think about how do we explain a complex situation, a diagnosis, a treatment plan. And I think really doing that teaching experience, you get comfortable speaking in front of people, you get comfortable thinking about organizational skills and speaking skills. And so I think that was a very useful thing for me. I went back to Texas for medical school and did my medical school at University of Texas Southwestern in Dallas. Didn't do much research at that time. It was largely just clinical work, kind of experiencing all the different things that happen in medical school. And then I went up to Johns Hopkins in Baltimore and did my internship and residency. Internship is the first year of your residency program, and then you're usually 2 more years for internal medicine after that. And then I stayed on at Hopkins to do my fellowship. And at Hopkins, they kind of do things a little wonky, where after your first year of fellowship, you then go back to be a chief resident, which is one of the lead residents, the senior residents for the internal medicine program for a year. And there you're doing mostly teaching, administrative duties, and some clinical care. And then I came back to pulmonary critical care research. And that's when I really started getting interested in actual clinical research. So I actually took a year off and got a master's in clinical research. So this is a master's in health science degree. Some places it's also a master's of public health, where you take formal courses in epidemiology, clinical trial design, research ethics, biostatistics, kind of all the skill sets you need to be able to conduct research. And during this time, I started working on research projects during my fellowship. So some of these were largely what we call analytical projects. So we had access to large databases of people followed for many years with, in my area of interest, was COPD or emphysema, chronic obstructive pulmonary disease. So we would do statistical analyses to look at things that may impact lung function changes over time. I also was involved in doing some research, helping write protocols for clinical trials of treatments for COPD, like oral treatments for COPD. So that was sort of my first clinical research. And I really enjoyed that a lot more than trying to harvest chick photoreceptor cells in the dark. And so I think that pushed me that way. And then I ended up staying on faculty at Hopkins. After finishing my fellowship, I stayed on faculty at Hopkins for about 6 years. So I was there through 2010. And then as I went through life, I met and married now my husband. He was in DC, I was in Baltimore, and we got married in 2015. He's not in medicine. And after, I always sort of joked that I had been, didn't want to die acutely or chronically in Baltimore because I wasn't from there. And so I decided after 16 years, we picked up and came down here to UNC. My husband had some ties here, used to live in the area. And there was a unique opportunity for me to help to build our COPD program, and it all sort of stars aligned. And then I joined faculty here in 2016 and have been here since. So different path, but interesting one, I guess. I'll toss it back to Kunal.
All right. So next, we're going to kind of talk about what a week in our lives look like. And again, we're giving kind of 2 different models for each of us. One is like when we're in the hospital, so something that we call on service. And then the second is sort of a more typical week where we're not on service and we're kind of doing a mix of a lot of different things. So, for me, I'm not on service this week. So this is a good example of what my week's been like. Mondays are kind of, I'm not seeing patients, but I'm still doing clinical work. So there's responding to patient calls from the weekend, there's finishing notes from patients I saw the week before, and there's preparing for my Tuesday clinic. So I read their charts and try to understand what may have happened since I last saw them, or if it's a new patient, kind of going through the paperwork. And one of the fun things about academic medicine is we're usually seeing patients that other doctors have tried to help, and they're a little bit more complex, and they're coming to us for our real sort of specialty expertise. And so there's usually additional work that we need to do. And one of the things I enjoy the most about working here at UNC is we get to take care of the people of the state of North Carolina. We have a wide diversity of patients, that from the mountains to the sea, from big cities to rural areas. And so you get some patients that really know their healthcare super well, and some that don't know it nearly as well. And so I think both Brad and I will spend this extra time kind of going into the chart, trying to get to know, so we're as prepared as possible and we can make the most out of this visit. I usually also try to set aside time on those Mondays for doing some teaching. So I have a position where I am helping first and second year med students with study strategies and adjusting to medical school. So I'll often do meetings with them during that time. And then there's almost always like a lecture or a talk I have coming up, and I'll try to use that time to kind of draft those lectures or refine those lectures, kind of brainstorm about education projects. So that's kind of like the way my Monday works. A lot of it, there's more flexibility, and it's kind of up to me to decide how I distribute my time. Tuesday, I see patients in the morning time from about 9 to 1 o'clock. It's usually a mix, depending on new or old patients, about 5 to 8 patients. There's usually a division meeting at the end of the day or a journal club that I try to make as well. And there's always some hustling because my wife is also, like I said, she's a physician. She sees patients on Tuesdays too. So there's always like a rush to make sure we pick up the kids in time. So Wednesdays, I have morning, and the morning I have free, but I'm usually finishing up my Tuesday clinic and preparing for my Wednesday afternoon clinic. And then Wednesday, again, I see patients in the afternoon. Thursday is I try to, in the morning time, finish up my clinic from Wednesday, again, returning calls or reaching out to patients that have something's come up since I last saw them. And then I teach in the medical school, a small group of about 7 to 8 students. I teach them longitudinally over the first 2 years of med school too, about how to take a history and physical, which is how it's basically the basic interaction that we have every time you go to see the doctor. The doctor asks you what's going on, tell me what problems are bothering you, and coming up with that treatment plan together. So there's the skills involved in how do you actually ask patients those questions and how do you do a physical exam. So it's a longitudinal group that I teach, and it's something I've been doing now for 3 years, and I really, really enjoy it. And then I also have some dedicated time on Thursdays where I'm teaching to the fellows. One of my areas of expertise is a disease called pulmonary fibrosis, or a set of diseases called pulmonary fibrosis, just scarring in the lungs. And so it's not extremely common, and even our fellows don't see it before they come into a fellowship. So we do a twice a month conference about that involves a mix of teaching and case discussion. And then I usually have some administrative task during that day too. So planning meetings for the School of Medicine physician or other meetings I'm having. Then Friday, I see patients again in the morning time. And then in the afternoon, there's some fellowship education conferences that both Brad and I attend. So it comes out to about 3 half days of formally seeing patients, and then probably another good couple of half days of kind of catching up with patients. And then the rest of the time is mostly sort of teaching and administrative. What I didn't include here is I do also, like Brad was saying, we do a little bit of everything. So I have a couple of research projects that I am contributing to on the side. So, clinical research projects where we're looking at how patients feel on a new therapy for pulmonary fibrosis. And so it's a project I have going on with another colleague. And there's do another research project. I'm looking at burnout in the medical ICU. And so there'll be a couple of those meetings along the course of the week. But that's a much smaller footprint for me versus like when you see what Brad's week looks like. But I didn't want anybody to think that we don't do that, but we get to do a little bit of everything. That's what we enjoy so much about doing academic medicine. So then that's my off service week. When I'm on service, taking care of patients in the hospital, most of for me, that comes out to about 10 to 14 weeks out of the year. Lately, it's been mostly the medical ICU that I do. And so that'll be 7 days straight. We'll come on take over on Monday, and that'll be my team I'm in charge of until Sunday, the following week. These are longer days. They're going to be about 10 to 12 hours. I usually arrive around 7:30, and I'm usually there till about 6 to 7 o'clock at nighttime. We do occasionally have parts of weeks where we're working in the evenings instead. And what I enjoy about it is I get to work with that whole group of people that Brad referred to before. We're working with medical students, we're working with interns and residents, we're working with pulmonary and critical care fellows, and then we're also working with an awesome multidisciplinary team in the ICU. So respiratory therapists who help run ventilators, nurse practitioners and physician assistants that also help take care of patients, critical care pharmacists. The UNC has a wonderful school of pharmacy, so we have some really world-class pharmacists that we get to work with, and wonderful critical care nurses. And so we all work together to help take care of these patients that are having one or more organs that are failing. And it's a mix of patient care, like me coming up with plans, talking to patients and their families, teaching at the bedside. What do you do when the ventilator is doing this? What do you do when the ventilator is doing that? And then also mentoring. So especially for our fellows, in a year or two, they're going to be the ones leading these teams. So giving them feedback on how do you lead a critical care team? How do you work with everybody? How do you interact with patients and their family? So it's a mix of all of that, and it's something I really enjoy. And you can do this type of work outside of academic medicine, where you just go see the patients, come up with the plans, and let the nurses and respiratory therapists know. But it's that opportunity to teach and mentor that we really enjoy so much. I'm going to talk. I apologize if you can hear a small person yelling in the background. He loves singing, and sometimes it's hard to control. So yeah, I'm going to talk about two quick examples of patients that I take care of. So one is a patient that I might see in the intensive care unit. This is a patient from last summer. She's 75 years old. She had mild diabetes, but otherwise doing pretty well. And she went to the beach. And then about a week after the beach trip, she started to have a cough and ended up being positive for COVID, which, as I think everybody knows, is a virus that's been going around and causing a lot of problems. And so when she came into the emergency room, she was really short of breath, and her oxygen levels, so normal oxygen levels are 94 and above, 95 and above. Hers was 55%. And she ended up needing a breathing tube getting placed in the ER. And this is what her first chest x-ray looked like, where this thin white line right here is the breathing tube. And then the lungs, which should be mostly sort of a clear black color, all this extra sort of white haziness is both infection and response to infection, inflammation that's filling up her lungs and then making it hard for her to breathe. And so, over the course of for me, a week taking care of her, but then for her, it was a several month stay. We worked closely with respiratory therapists, pharmacists, NPs, that whole multidisciplinary group, and the critical care nurses to help stabilize her. And sometimes I joke that it's like, when these patients are this sick, it's really, we're just taking it a day at a time. I don't know if people are Game of Thrones fans, but there's they refer to, what do we say to the god of death? Not today. And sometimes they say we have these patients that are really, really sick, and we're just trying to make small progress every day and get them better. And even though she was, 75 is very old to have a breathing tube in and do well, she ended up doing okay. And it took several months, but we were able to get her out of the ICU. A patient I might see in clinic is a 65-year-old man who is a former smoker. He's coming in to see me after 6 months of developing shortness of breath. He also had a little bit of a cough that's constant and dry, meaning there's no sputum that's coming up. It's just kind of a hacky cough. And when I listen to his lungs, he has what sounds like Velcro in the back when I listen to the back of his chest. And so that's known as crackle. And then when we check his oxygen, it's sort of like 88, 90%, so lower than we'd expect. And this is what his CAT scan looks like. So for a CAT scan, it's a cross section of the chest. So this is kind of going through the level of the heart. And all these like holes along the edges and extra white lines are very abnormal. That's fibrosis that's developing in their lungs, in this patient's lungs. So he has a condition known as idiopathic pulmonary fibrosis. And so we can start medication, or we started medication to help stabilize this fibrosis and prevent it from worsening. We started him on oxygen to kind of raise his oxygen levels. And then we have to monitor for complications. And this is somebody that I will see on a regular basis for about every 3 to 4 months. Most of these patients will stabilize for a while, but always in the back of my mind, I have to start thinking about when things worsen, how do we help prepare for end of life conversations and the support he's going to need at home. And that's not a fun thing I enjoy doing, but building that relationship over time is really important, and something I do enjoy. With that, I'm going to hand it over to Brad and go tell my child to be quiet.
Yeah, so I think that you'll kind of find that there's some similar themes to what we do, and again, a lot of it revolves around clinical care, but I, like Kunal, also have times where I'm on service or not on service, or we go off service. And so what you seen here is sort of my representative week when I'm not on service, and we kind of color coded it a little bit. And typically on Mondays, most of my free time, if you will, meaning time I'm not spending in clinic, I'm actually doing clinical research. So that means that I'm engaging, recruiting patients for different studies. We're actually conducting research visits. We have studies, for example, where we're trying new pills, for example, to treat chronic lung disease. And so we have some patients, everyone's enrolled in a study after an informed consent, and half of them get the active pill and half of them get placebo, and nobody knows what they're getting. And we'll follow them for lung function outcomes and breathing difficulties and those sorts of things. So we're doing those visits themselves. So the patients are coming to our research site, and we're seeing them and examining them and getting their history. And the other reality is that in order, I may have a lot of interesting research ideas, but I have to get somebody to pay for them. So I don't have the money out of my pocket to go fund a clinical trial. So what we do is we write what are called grants. So a grant is basically an application. It could be to the National Institutes of Health. It could be to a foundation like the American Lung Association, or even something within UNC. So UNC has money set aside for research studies. And we write grants to sort of say, hey, look, I think I have this really cool research idea. Here's why it's important. Here's what's known about it. Here's the objectives of my study. Here's how I'm going to do them. Here's what I'm going to do if the objectives don't work. Here's how much it's going to cost. And will you please give me money? And so we spend, you may have just sort of to give you an idea of scale. So a 4-year, $500,000 a year grant from the National Institutes of Health is written in 12 pages. So the science itself, you have to condense down to 12 pages to convince a group of your peers who are anonymously reviewing your grant to give your institution $2 million. Actually, it's more than that, because the institution, there's a roundup by the NIH. So we spend a lot of time writing these grants. The success rate on the first submission is 10%, 12%. So these are often things that are iterative, but that takes up a lot of time. And that's where you actually get to really think about the science, develop the science. And then when you get the grant, you get to conduct the science. So on Mondays, I'm doing research visits. I'm thinking about science. I'm writing the grants. And then the fun side for me is on the other side, when you've completed the research, and now you get to share it with your peers. So the way you share it with your peers is through scientific publications. You've seen all these, in the New England Journal of Medicine, this vaccine has done great. Well, those are all scientific publications. So somebody has to write those. So that's what we do on the back end, is we write those. So we spend time doing that. And then maybe that's where my English major part sort of helps out with the writing there. And much like Kunal, while I'm doing that, sort of the world of multitasking, you're also dealing with things like patient calls, needing prescription refills, urgent, calls, those sorts of things. And then to a lesser extent for me, sort of drafting lectures. My formal teaching is a little bit more intermittent. I may give 2 or 3 lectures to the fellows on my area of expertise. I may be asked to give a lecture to another group. I gave a lecture last week to a group in Singapore virtually on electronic cigarettes, which is an area of interest for me. And so it's sort of developing those lectures, but that's a much smaller share of what I do. And then much like Kunal, my clinic is on Wednesday. So I see patients all day on Wednesday from 8 to 4:30, typically around 12 patients. So that means Tuesday I'm prepping. And it's usually, 3 to 4 hours of prep based on the number of patients I'm seeing. And so I think, it's hard to see a chronic illness in 20 or 30 minutes with a patient. So that's why that preparation part kind of, really pays off. So we all spend time pre-prepping for clinic. And then I have administrative meetings with my research team. I'm on a clinic leadership role with the division. So I help oversee the outpatient clinic. So having meetings about, issues going on with the overall clinic function. And then Wednesday, I'm a doctor. I'm seeing patients all day, doing notes, and dealing with those things. And then much like Kunal, Thursday, I'm still doctoring. You're finishing your notes, doing patient calls, following up on labs or scans that you may have ordered during the test the day before. And then also seeing research patients. We're lucky that at UNC, our research space and our clinic space are geographically next to each other. And then Friday, similar to what Kunal did, say, I think patient calls, kind of working on papers, grants, doing some of the fellowship education series that we do every Friday with our fellows. So that's my typical kind of off-service week, if you will. So similar flavors to Kunal, but maybe a little bit different interests or different focus. And then when I'm on service, I also do inpatient medicine time. I do about 8 to 10 weeks per year. And I should say that the way these numbers are assigned is kind of based on what else you do. So when for a researcher, when I write a grant, we put in a budget, and the budget's partially to pay for the science. We need to pay for the assays or the supplies, but part of it is also to pay my salary to do some of the effort on that work. And so for me, if I have a lot of active research grants, then I scale back a little bit how much inpatient time I do. And then when I have less grants, I do more inpatient time. And I suspect, I don't want to speak for Kunal, but as Kunal extends his educational enterprise with the School of Medicine, that supports some of that effort, and he's able to kind of toggle up and down. And that's a very different thing than sort of private practice, where what you do is see patients and it's sort of more steady. So that's why you see these different numbers. But I generally do 8 to 10 weeks per year. I do medical ICU, like Kunal was describing, and as does Kunal, also does the pulmonary consult service. So this is a service in the hospital where, when other physicians who aren't lung doctors need help from a lung situation for a patient that's hospitalized, they'll call us and say, hey, this patient got admitted for a knee surgery, but she's really short of breath, or her x-ray was unexpectedly odd. Can you come tell us what you think is going on and help guide us through that? So that's called a consult service. And most of us in pulmonary critical care will do consult service as well. In the ICU, it's again 10 to 12. ICU is typically 10 to 12 hours per day, mostly day shifts, very similar to what Kunal was describing. And the consult service is the same. The consult service, you're often with a fellow resident, so it's much more of that teaching opportunity, much like the ICU. But you really also, I think it's fun because you get to help out your colleagues who may not think about pulmonary medicine. And it may be you're seeing a patient in the cardiac ICU, or you're seeing a patient, who again had a blood clot after a knee surgery, or somebody who is on oxygen and nobody knows why. So I think it's sort of a fun kind of grab bag, if you will, of all the different pulmonary diseases. And that's my typical on-service week. And so then to describe kind of the patients I see, so this for the inpatient pulmonary consult service, so you can kind of just advance there. So this is the kind of question that we get called about. So the oncology service has an adult patient who's getting chemotherapy for lung cancer. And he comes into the hospital because in the chemotherapy suite, he's actually more short of breath than normal. And that's unexpected because he's getting treated for lung cancer. He should be getting better. But they recognize he's more short of breath. His oxygen saturations are low. He looks more short of breath, and he gets a CAT scan of his chest. And it shows that on both lungs, there's these very non-specific shadows in both lungs. And you really can't tell from the CAT scan. It shouldn't be there, but you don't know what it is. And when we think about, well, what could it be? We call that a differential diagnosis. So the differential diagnosis is all the list of things that could be explaining what we're seeing. So in this person, well, maybe he's having lung toxicity from his chemotherapy. Maybe he's got an pneumonia because he's got a weakened immune system from his chemotherapy, or maybe this is his cancer and it's actually getting worse despite his chemotherapy. So that's the question the oncologist posed us: is this guy short of breath? He's got an abnormal CAT scan. What do you think is going on? And one of the services we provide is we can do a procedure called a bronchoscopy, where we actually go into the lungs with a camera to collect a specimen. We can look for inflammation. We can look for tumor cells. We can look for infection. And I think Kunal's going to pop up a quick video. We don't have to do the whole thing, but just to show you what it's like to go into the lungs. They're kind of cool. Yep, you can see it perfectly there. So if you hit, yep. And so we're basically with a camera that's going into the lungs, and this is the vocal cords right there. And you're looking down the windpipe. And as you go down into the lungs, you're kind of just going to cruise down it. And I love this. This is like what your lungs look like from the inside once you get past the vocal cords. So that's always a little tricky because patients like to cough and hopefully not talk, but you can see down into the airway. That's the main trachea, the one you can feel on your throat. And that's kind of where you're heading down right up front there. And you're going to go down to the bottom, and you'll start seeing a branch. They're just pointing out the rings, which are the front part you can feel on your throat, and the back part's the very soft part you can't feel unless you're wrapping your finger around the back of your throat. And then you kind of get down into the lungs, and there's the right lung and the left lung. And we don't have to show the whole thing for time, but this is sort of what we do. So we go down with a camera, and we can get a good look at the lungs and collect a specimen and then send that to the lab and help inform our colleagues in oncology about what's going on and hopefully give them an answer. So that's sort of a cool thing for one of the fun procedures. And then you totally switch gears, much like Kunal was saying. Now we're in the outpatient side, my Wednesday clinic, and I see patients who typically have or are thought to have COPD, which is a tobacco-related lung disease, chronic obstructive pulmonary disease, or emphysema. So a typical patient, I was in clinic today, elderly woman comes to clinic because she's short of breath, and her doctor of primary care thought, well, maybe you're just getting older and that's why, but you did smoke. So why don't you go see the lung doctor, and we take a little history. And she's been smoking a pack a day for most of her 35 years. She has a lot of regular cough and phlegm, and every now and then she has to go to the hospital because of shortness of breath or go to the emergency room. And when I listen to her, unlike the crackles, which is what Kunal heard, I hear wheezing. So kind of a high-pitched noise that's got different tones to it as they're breathing out. And that's very typical when airways are swollen and narrowed, almost like the neck of a balloon. When you let the air out, you hear that wheezing. That's what we're hearing in the lungs. And then we have her do some breathing tests, which we call spirometry testing, which is where we're going to measure her lung function as she blows out. And it finds out that this is all consistent with COPD. So once we made that diagnosis of COPD, then we get to do some things to help make her better. So I think if you advance the slide, we talk about ways to help her quit smoking. We started her on some inhaled medications to open up the airways, to decrease the inflammation. We see her back in a couple months and she says, I'm doing better, but I'm still not feeling great. So we titrate up her inhaler some more to try to get her better. And this is where I think one of the things that I personally really enjoy is you get to have these really longitudinal relationship with patients. I mean, I have patients who I've met on the first day of my clinic here 6 years ago, who I'm still seeing every 4 to 6 months now. And it's just really nice to have those, to see people that you're really long-term improving these chronic illnesses. So that's sort of my kind of patient base. And then I throw it back to Kunal.
Yeah, I want to add that too. Like sometimes we'll see patients in the hospital, like either in the ICU or the consult service, that we then get to see in the clinic, which is also awesome. I remember taking care of a patient in the ICU that was so sick. We're talking about all the organs that can fail. He had all of them down. His blood pressure was low because his heart wasn't working well. He was barely avoiding a breathing tube. His liver was failing. His kidney was failing. And we did a lot of different things. And I saw him in clinic. He was actually seeing a colleague of ours in clinic 4 weeks later. And I just kept coming in there and being like, I can't believe you look so good. Like you're here. And it was just, a very rewarding experience for me. And I, of course, shared it with the whole team. And there's some of the patients I was talking about with COVID, they've been in the hospital for months. I now see them in clinic because some of them have some fibrosis that needs following. And so again, that's a really rewarding thing to see them emerge from all of this, and that relationships that we built over time in the hospital continue to play out for us as in the outpatient side. So with that, I think we're going to close with some like tips and lessons that we learned. So I think we're each going to kind of talk about some key points. For me, and this has been a theme that's been coming up a lot throughout the hour, but academic medicine, it allows for a lot of different roles, and I would embrace that and embrace it in your journey and in your training. All of you will, if you just go into medicine, you'll get a chance to be exposed to all these different roles as part of your time in training. I think doing those different things and trying out those different things will stretch you, but it makes you better. And for me, having spent so many years doing lab research, it may seem like, well, why does that make a difference now? But it helps me understand the science better. And so when I have learners who are very interested in science, I can connect with them about that. It helps me stay on top of my sort of clinical game because I can understand the background by which we now do these things. And then it also just kind of, there's a discipline that you learn from doing research of any kind that's really applicable for your clinical practice. I think overall for medicine, it's all about lifelong learning and teamwork. I think as I work with like first and second year med students, one of the hard things is that the idea that things are going to keep changing and evolving, not just the information, like they won't change so fast in the time that you're within the hematology block, the facts all stay the same, but like you may need to change over the course of the year how you're studying and approaching things. And that's just a good skill to start learning because that's the field. Like that's the nature of medicine, is always kind of adjusting and reflecting on what's going well for you, how are you able to do the job best, and how do you keep getting better at it. The transitions are always going to feel hard, but again, I embrace that challenge, and how you adapt to those changes make a big difference. And that leads to I think one of my top 3 points, which I close with. So one is that don't let when you're learning or when you're in this process, I was always made to feel that there's some single moments that matter a ton, whether it's your MCAT score or your later on when you're in med school, your board score or whatever, your step 1 score. There is no single moment. There are things that are important, like don't blow off your MCAT. Like you should study for the MCAT and do those things. But whatever the score is, how you respond to it, how you handle that, how you apply lessons learned from that journey of studying for it, that's going to make a bigger difference than just that number. Also, not letting others define success for you. Throughout this whole journey, you figure out what really matters. And some of it's trying a lot of different things. But once you figure out what matters for you, then go and seek it. but don't let other people say this is what's important. And for my own journey, because I invested a lot of time in basic science, I did have some wonderful mentors that I really care about, and they care about me, really telling me, you need to stay in science, you need to stay and do the lab. But I just didn't enjoy it enough anymore. And where my passions lied was in teaching, and that's where I wanted to go. I have other friends that were doing teaching and then realized their passion was in clinical research or in basic science research, and they needed to follow that path. But kind of listen to yourself and where your heart's leading to. I have a mentor that would say, like, let's assume I dropped you in the middle of the medical center, and your feet could take you anywhere. Where would it go? Would they lead you to the lab? Would they lead you to the clinic? Would they lead you to the classroom to teach? Trust that instinct of where your feet are leading you. And then last bit is, I can't overemphasize the importance of mentorship. And this is mentors in all ways. So, mentors about the type of career that you want, mentors who seem to have a good work-life balance. I am not that mentor for people, but if you find somebody that kind of has a lifestyle that fits and that does the things outside of work that you really enjoy, like, talk to them. How do you have kids in this field? How do you balance research? If they're clinical leaders or administrators that appeal to you, go and talk to them. Likely you're going to need a lot of different mentors for different things that you're interested in, but there's nothing that can replace that relationship that you build with people and them and just learning kind of what their experience is. And most of us, especially in academic medicine, we enjoy doing that. And we're happy to meet with people and just kind of show them and share with them our journey. I will say, though, the reason you need to seek people out is mentorship it's two ways. It's like you feeling a connection with them feeling a connection with you, and then you can build off of that. You'll be assigned mentors along the way, but that's never as good of a duplicate for, like, hey, I just like working with this person and they seem to have some common theme to what I'm looking for. Let me go talk to them and we do that. I remember that as a med student, seeing somebody who was a physician in the ICU, and I loved working with him and seemed to, like, have all the same values that I really enjoyed about the field. And I knew they were also partnered with somebody that's in medicine and had kids. I'm like, oh, well, at that time we didn't have children. I'd love to talk to them about how they do that. And so he met with me, even though I was just I guess at that point, 7th year med student. And then some of the lessons he told me then were helpful even down the road. So mentors. With that, I'm going to hand it back to Brad.
Yeah, and I'll say I fully agree with everything that Kunal just said. So I have only a small fraction of things to add because, everything he said is spot on and resonates very strongly with my experience as well. And I think those are all good lessons. You're talking to two people who went into internal medicine, and that's one of the sort of branch points at some level. It's a false branch point, is sort of this distinction between internal medicine versus surgical sort of specialties. So, and I think that this is where as you move into the medical school career and start thinking about sort of what you're doing with life, you really have to think about kind of what kind of person are you to help inform some of these decisions. And I'll give you the example. So my dad is a retired gastroenterologist. So and he was a proceduralist. So he was a stomach and colon doctor who did colonoscopies all day and endoscopies, which is put a camera down into the lungs. And this was in the 70s and 80s when they were just starting to do these. So, and I came home from my first rotation of medical school and said, I want to be a trauma surgeon. And, I did a trauma surgery rotation, my third month, Parkland, Dallas, craziness, bullets and blood and all that. And, all that. And I was like, I'm going to be a trauma surgeon. He's like, no, you're not. And I'm like, why not? He's like, you hate fixing stuff. He's like, if the toaster breaks, are you going to fix it or buy a new one? And I'm like, I'm buying a new one. He's like, exactly. So you have to think about, and I sort of unfairly said, are you a thinker or a doer? That doesn't imply that surgeons don't think, but, we do a lot more thinking over doing. We do a couple procedures, we do some procedures that they're in targeted areas, but a lot of our time is spent talking and critically appraising data and those sorts of things. Whereas a surgeon is, their joy, I think, is being able to fix something, right? Here's a problem, I'm going to fix it. A broken femur, needs a coronary bypass surgery for a heart attack, et cetera. So thinking about who you are and doing some introspection there is important, because you have to be, if you land in a place that just doesn't resonate with your sort of ethos, that's going to butt up against you for the rest of your life, right? So I just, think about what you enjoy doing and how do you spend your time. And much like Kunal said, medicine is incredibly diverse. I mean, you're in a candy store and you should taste every kind of candy before you decide what you want to do. So explore it all. Ask people what they enjoy. Why does the ophthalmologist enjoy what they do and the pulmonologist enjoys what they do, right? So just trying to understand what people enjoy about what they do. And I think hopefully we've given you some ideas about what we enjoy about pulmonary critical care medicine and academics. As I said earlier, I think being a teaching assistant is so helpful. It helps you frame teaching, it helps you frame communication. And this is such an applicable skill both to patients and to colleagues and learners. And so if you have that opportunity, that's something that I think I look back and now realize how much it probably continues to help me on a daily basis. Today I was sitting in an exam room trying to explain to a patient a very complicated genetic cause of COPD, and it's being able to sort of think about how am I going to get this across in an effective way where there's a meaningful understanding on their side. I think really those skills come from thinking about how to teach. And also focusing on public speaking. I did speech and debate in high school and a little bit in college. And so I think being comfortable with speaking in front of groups, if you're going into medicine, that's going to be part of what you do, whether it's private practice or academic. So I think thinking about doing those sort of activities to get comfortable with that experience, because that shouldn't stand in the way of doing what you want to do. And then ultimately, you have to do what makes you happy. If you end up in a path that you're not happy with, you will probably not find happiness, right? And so I think it sounds silly, but Kunal described sort of realizing that virology work was not his life's wishes. I perhaps was lucky enough earlier on to figure out that photoreceptors, were not mine. But just being able to, I was in a large institution in the Northeastern Seaboard and one of the top 5 institutions in the country for what I do. But I realized that that's not what I want to do my whole life. I didn't want to live on the East Coast. And so picking up and moving and having all these awesome new opportunities has totally improved quality of life and improved my science, my research, my patient interactions and everything. So do what makes you happy. So I think that's all I had to say. And I don't know, Kunal, if you have anything else, or we can open it up for questions or comments or anything that's useful for you all.
Thank you so much, Dr. Drummond and Patel. That was a great presentation, and I definitely learned more myself, and I'm sure all the other club members did as well. So that being said, CHSS members, if anyone has questions, you can unmute or send it in the chat so they can be answered.
We're both going to put our email addresses in the chat too. So if you guys think of questions later on, feel free to reach out to us as well.
And here for CHSS members is the Google Forms for the attendance tonight. But yeah, if anyone has any questions, maybe we can squeeze in a couple. So I do personally have a question. So Dr. Drummond, you were talking about how the first time approval rate for, I guess, proposals was only 10 to 12%. And I think that sounds a little bit, I think maybe demotivating, but how do you work through that, and how do you collaborate with your peers to improve and then resubmit?
Yeah, so that's a great question. And I think that's one of the, that's one of the challenges of what I do, right? So it's, you're going up to bat and you're striking out. But the beauty of the system is that, and I will say that 10 to 12% is in the current NIH pay lines with the budget deficit and all, it fluctuates, it fluctuates with what Congress does, so your votes matter. So voting for representatives who support the NIH increases the budget, which means they have more money to give out. And that's what decides those so-called pay lines. But the beauty is the process is that you don't just get a thanks, but no thanks. You get a no thanks, but here's everything we thought you could do to improve it. And then you can revise it and reapply. And most grant it's a 10%, 12% first pass. But when you submit that revised application, you're now up to 30, 40%, right? So, and rarely do you have just one, I often have 3 or 4 grants that I'm sort of shuffling through and sort of massaging and improving and resubmitting and refining. So and at the end of the day, I've looked at my grants that have got totally trashed, as I call it, the first time, and the one that got funded, and invariably there's such better science. And it's never a process of no thanks, move on. This is an interesting idea. Here's how you need to make it better to sort of help it rise up. So it's a process. Yeah.
And, we do a lot of this idea of there's right answers for everything. We were talking about that before in medicine, but in this entire field, including both clinical and research, when you're getting things wrong or you're not initially succeeding, you're actually learning. And that's thinking about your response to things. So when you don't get the grant, it's how you react to hearing the revisions, taking a step back and doing, and going forward. That makes a big difference. Like when I was in the lab, a lot of those experiments did not work. And, my mentor would be like, that's okay. If every one of your experiments work, you think about a successful researchers having for their own individual work that they're doing solely by themselves, if they get a couple of papers, out a year, that's fantastic. And that's usually a series of 6 to 7 experiments. I mean, 12 experiments work in a year, that's great. But that doesn't mean you're doing 12 experiments a year. You're doing many more than that are failing. And then hey, let me think about why that didn't, work. And then you go from there, you make those revisions. So
that makes a lot of sense. Thank you.
It still stings a little bit, but
yeah.
I'm not gonna lie, you get over it, so.
I remember like you read the initial reviews, you read it, you have your emotion, then you put that aside, and then you come back and look at it calmly. I'm like, okay, hey, I can do this.
Yeah. We've all gotten bad grades, so.
Any other questions before we wrap up tonight? Okay, I have one more question and then I guess we can head out. So how is work-life balance? Because I know you both mentioned like some days, I think Dr. Patel, you said you were there from like 7 a.m. to like maybe 6 p.m. That's a long work day. So how do you both manage it with your personal lives?
Yeah, I think a start is something we each emphasize, and Brad particularly emphasize, like make sure you're doing what you love, right? So like there's a saying sometimes like, oh, if you find something you love, you never work a day in your life. Well, that's not true. I mean, it is work, and I enjoy sitting at the beach with my children and like reading a book as much as anybody else. But, making sure you're doing what you enjoy and you find satisfaction from the work is really important. It makes those days go easier. So even like the ICU, I love being there and I love all the things I get to do. It makes that day go by faster. I think this is where, for me, work-life balance I've gotten better at is through talking to people. And, our jobs, generally speaking in medicine, they are reasonably paying, right? We're not just barely getting by. And so knowing how to use those financial resources to simplify your work, like what can I pay somebody to do that frees me up to do things I enjoy and build quality time is really important for making that non-work time as efficient as possible. And then the work time, it's again, like this is my 3rd year as faculty. So I look at the way Dr. Drummond does his notes, how Brad does his notes, like, oh, what are hints that I can do more efficiently? And I try to pick his brain about that. And I think learning from each other will help. And then constantly reflecting. It's an iterative process. So reflecting, being like, I just did a MICU rotation. I got out way later than I thought. I was paired up with somebody on the other team that would seem more efficient. Let me go talk to them. And one of the things that, it's a small thing, but like part of our responsibility is like you need to see a patient every day at some point. And I was doing one of these things where I'd come in and review all the things on the computer and then see the patients later on. And a colleague of mine suggested, why don't you see the patients first thing in the morning? Because not all the information's coming in is there when on the computer at 7:30, but the patient is. So you go and see the patient. And then when we meet as a team and discuss the patient, I've already seen and examined the patient that can help me come up with a better plan to be more efficient. And so it's like a little tidbit like that made a big difference for me and helped me get out a lot earlier. I'll let Brad answer too.
Yeah, I mean, I think that, and I agree with everything that Kunal said. And, the reality is that for every week that you have to work, a 12-hour long day in the ICU, you have flexibility on those other days. I mean, I'll give an example. Today, I was in clinic this morning and I chipped a tooth yesterday and I was able to get in the dentist at 2 this afternoon. So I left at 2 and I went and got to my, the numbing medicine finally wore off before this call. But, I came home and did a little bit of work from the afternoon from home right before this thing, so there's a little more flexibility that kind of balances things. I also think you have to set some boundaries, and boundaries are always meant to be broken. I have this on my email thread and I sort of laugh when I see it because people remind me. I say, like, please note, I strive to be email free at night and during weekends and holidays, but often find myself sending emails during those times. I do not expect a response from you during those times. So that's on my signature line. I break that rule all the time, but that's like a goal, right? And so I think, and acknowledging that you need to take time, stepping away. There's a lot of emphasis now for us in critical care with the COVID sort of pandemic burnout that we're trying to do for work-life balance. And it works, and you rely on your colleagues. And Kunal and I may be in the ICU together. I'm like, dude, I really need to like get out of here today. I have not been home for dinner in 4 days, and he's like, I got it. You go, you cover me tomorrow night. I'll cover you, so there's always that sort of, there's ways to make it work, and it works. I think otherwise we'd all be fleeing for the hills or the beach.
Yeah. But then, as you find fields that you like, it shouldn't be I wouldn't say let that be the only reason you pick a field, is that work-life balance. But if you find a field you're interested in, try to find people within that field that seem like they're doing it well and talk to them about how they do it.